Welcome to the Clinical Excellence Network. My name is Joe Braithwaite. I'm presenting a patient I am seeing with low back pain, TBC manipulation. My patient is a 65-year-old male deli clerk. His chief complaint was low back pain and gluteal pain, especially on the left side. The date of his injury was on September 13th, 2012. The date of our examination was the 20th of September. It's only 7 days later. The self-report scores outcome, Ostwestry Disability Index score was 24 out of 50. I set a goal to get 0 out of 50 in 4 weeks. The FAB-Q was a 51 on the, so he's kind of got high fear avoidance. Predicted number of visits about 12, in about 4 weeks. My patient's primary complaint, or P1, is low back pain. Worse is 10 out of 10, best is 0 out of 10. Currently it was about a 5 out of 10. Aggravating factors include standing, sitting, picking up objects from the floor, putting on his shoes. An easing factor include lying down, taking ibuprofen or muscle relaxing medications. T1 is instant with squatting, about an hour or more with sitting, and 25 minutes in standing. T2 is a few minutes to hours, depending. P2 and 3 I put together. P2 is the left gluteal pain. P3 is the medial right gluteal pain. Worse is 10 out of 10. Best is 0 out of 10. Currently 1 out of 10. Same aggravating and easing factors. Also same T1, T2, because all pain occurs together. The patient reports difficulty rolling over in bed, and symptoms being worse in the afternoon due to activity throughout the day. So the sleeping 24-hour pattern is more activity dependent. The past medical history is unremarkable. He's progressing slightly since the accident by himself, and with the pain muscle relaxing and ibuprofen, but just a slight improvement. He has not received any previous treatment. Here are some of the structures that may be contributing to the pain: the joints, the structures, and contractile tissues. Just pause the video and take a look at that if you like. My initial hypotheses were primarily low back pain treatment, mechanical low back pain, TBC manipulation, and then TBC specific exercise, and then hip dysfunction. There was an unremarkable medical history, no red flags or yellow flags. The patient is not taking any medications beyond ibuprofen and muscle relaxants, and the imaging that he had radiograph was negative. So I use forward flexion, tying his shoes, or squatting, lifting objects from the floor, and rolling over in bed as my asterisk signs from the history. So I have not yet ruled out any hypotheses with the history, and so they will stay the same. So the severity I consider to be moderate. Irritability moderate as well. The nature is musculoskeletal. The stage is improving slightly, and then its stability is it's consistent and reproducible. So I will use the CPR for the TBC manipulation to rule in my primary hypothesis, rule in or out. I'll use the CPR for the TBC specific exercise for my secondary, and I'll use Altman's criteria and hip scour to rule in or out any hip OA or hip involvement. I plan to assess the lumbar spine and hip involvement and the short-term effect on lumbosacral manipulation the first day. And then the second day more, I'll see the long-term response to hip lumbosacral manipulation. So the precautions and contraindications: because of the moderate severity and irritability, I'll be moderately aggressive with the patient. The postural observation was within normal limits. Forward flexion and squatting will be the functional movement asterisk signs. The quick screening test, walking on his toes and heels did not reproduce any pain. Squatting and trunk movements did increase the P1 and P2. I cleared the knees and the ankle, foot, and thoracic spine. The dermatome sensation and reflexes were normal and equal bilaterally. So the range of motion for the lumbar spine was 30 degrees flexion, 20 degrees extension, 10 degrees side bend on both sides, with the following pain. The hip was 30 degrees internal rotation on the left, 35 on the right, and there's no increase in pain. Same with external rotation, and flexion was within normal limits, but he reported increase in P1 and P2 with at the end range of flexion. The manual muscle test was perfect for the right, not really, I guess a little bit painful with the hip testing, and then the hip was pain limited on the left, with also on the knee extension and flexion, just pain limiting. Palpation of the lumbar musculature reproduced some pain locally, and there was hypomobility in the lumbar spine with increased pain while performing the PAs. Special tests were negative slump bilaterally, negative Gower sign, negative pit. The straight leg raise did reproduce symptoms bilaterally at about 50 degrees on both P1 and P2. Faber was positively bilaterally, reproducing P1 and P2, and the scour, hip scour, was negative bilaterally. The primary competing hypotheses, so still thinking TBC manipulation, since he satisfied 4 of the 5 CPR, and then the secondary specific exercise with signs of extension bias. The asterisk signs will be bending forward, squatting, like picking things up off the floor, and rolling around in bed. With treatment, I began with a sideline lumbopelvic manipulation. With this, decreased his P1 and P2 from 5 out of 10 to 2 out of 10 with forward bending, and increased his range of motion from 30 degrees to 50 degrees. So it was successful. The other two stretches I gave him were the lower trunk rotation and a bilateral gluteal stretch lying supine. He liked those, and just only reported minor painful stretch when he did the glute stretch, on the left side especially, but it went away when he was done. On a second visit, I asked him how he did. After last one, he reports less pain, low back pain and hip pain, gluteal pain after last treatment with activity. He reports 3 out of 10 low back pain that day with 60 degrees of forward flexion. Patient was compliant with his home exercise twice a day. He reported most difficulty with lifting objects from the floor, and noted that he'd not yet, even though he noted that he hadn't really tried it before, since before the initial visit. That day I again performed lumbosacral manipulation, decreased his low back pain to 2 out of 10 again, forward bending increased from 60 to 70 degrees, the hand heel rocks, and the 3-way straight leg raises, the bridging, the step forward and lateral on the 6-inch step, just reported minor low back pain, no more than 2 out of 10. And then I had him even lift a 2-pound box from the floor to the chest height, educating him on correct posture, keeping the box close to him, having a good shoulder width foot stance, and keeping an upright posture. He's able to do that with 3 out of 10 pain. So I just continue with the lumbosacral manipulation next visit, and potentially even a hip-directed manual therapy. I was thinking progress to trunk and lower extremity strengthening and structuring exercises as tolerated. So in the third visit, he reports almost no low back pain after last treatment with activity. He reports 5 out of 10 low back pain today, because with 50 degrees of forward flexion, he was compliant with his home exercises, but he hurt his back just lifting something off the floor, something light, but it tweaked it, made it a little aggravated. I threw a whole bunch of different manual therapy at him today, trying to turn off the pain, but I was unable to turn down the low back pain. This remained about a 5 out of 10 with both the lumbosacral manipulation, seated thoracic manipulation, long axis hip, and even hip lateral glides. He reported feeling a little bit better after doing some of the mini squats, seated marching, recumbent bike. Planned for the next visit, I asked the patient not to reach forward and down like he did, use correct posture if he needed to pick something up off the floor, and I planned on progressing manual treatments and exercises the patient can tolerate the next visit. So the fourth visit and on, the patient has improved since the third visit and reports 1 or 2 out of 10 pain, low back pain, and left gluteal pain with activity. He's better able to perform the asterisk signs like squatting and bending forward, especially when he squats with the correct posture. And he's actually planning on going back to work next week so we can see how he can handle that. If he was not to be 100% cured, what point would I progress in my treatment process? Would I cease, and why? And again, I don't expect this to be the case, but the patient's progress is, if he has plateaued, including no change in pain, mobility, strength, or function for 2 or 3 weeks in spite of manual treatment and exercise, I would begin to think about discharge. I just really do not want him to go to a orthopedic surgeon if he's got some low back pain, but if he's just plain not progressing, I mean, there are other things that can be done, including injection and surgery, but if at all costs, I keep him away from that. So the patient's final outcome, of course, I'm still seeing him. I've seen him for 8 visits. I expect to discharge him in about 4 more visits. He has decreased the Oswestry Disability Index from 24 to 17. And let's see. So he's able again to perform the squats and picking up a box from the ground with more weight, without pain, and is able to bend forward with just a 1 out of 10 low back pain, or left gluteal pain. So what I have done differently, I would have performed the lumbosacral manipulation, but also I would have remembered the hips. He actually responded quite well to the lateral glide with a belt. If I would have focused a little bit more on the hips earlier on, I could have potentially even decreased his pain a little quicker. I learned that, well, there's a psychosocial difference between cultures with respect to pain. He's actually from Taiwan. It seemed to me like it was either the pain was on or it was off. There's like not much of a variability. It was more difficult to get the information out of him, especially since he did not speak much English at all, just very halted English. His wife came in and helped. So it was interesting to learn that again. More is not always better with respect to manual treatments. I was, especially on that 3rd visit, trying to just decrease his pain through all manner of manual treatments, but that's not necessarily what we need. If he's irritable, and I'm not going to lower that down, most likely. So I just need to be patient with that and try other things. And so hypothesis-based reasoning is, well, it's helped me find that huge pain modulator. It decreased his pain quite a bit right off the bat, which was great for the patient. He was happy to see that his pain decreased so quickly. Again, I was hoping he would be the home run case, just be able to turn it off real quick. It's lingering a little bit, but I was able to find a treatment that was very beneficial for them. So if you have any questions, please let me know. I'll be looking forward to seeing and speaking with you guys on Tuesday. Thank you.